Today is the first of two Grand Rounds series sponsored by the Psychology Division, and I'm very pleased to welcome Dr. Lynette Abrams-Silva, who is a colleague from the Department of Psychology and main campus. And I had the opportunity to meet Dr. Abrams-Silva when she spoke at the New Mexico Black Coalition Mental Health Conference a few years ago. And so we're very pleased to invite her to talk about ADHD and cultural considerations. She is a board-certified clinical neuropsychologist and the director of the Psychology Department Clinic, which oversees the clinical training experiences and teaching in the department. She's a graduate of the doctoral program here at UNM and completed her pre-doctoral internship and a 2-year fellowship in Chicago at the University of Chicago and the University of Illinois at Chicago, respectively. She currently serves as the chair of the Ethnic and Minority Affairs Subcommittee and co-chair of the Strategic Planning Committee, both of Division 40. And continues to pursue mentorship opportunities for developing neuropsychologists. So welcome and thank you.
Thank you so much for that lovely introduction. The requisite, can I share my Zoom? I can share my PowerPoint on the Zoom. Time is right now. So let me see if I can share it, share my screen and make sure that everybody can see what I would like everyone to see. So let's see. How's that? Look good, everybody? All right, excellent. Well, thank you for coming to my discussion of attention and ADHD and our local diverse population. I have no need to reintroduce myself. That was a very nice introduction. Thank you so much. Briefly, a little bit of an overview and a little bit of a disclaimer. I'm going to talk a little bit about attention as a thing. And then discuss a little bit about ADHD. And there's an asterisk there because it is from an adult perspective. And I'm sure there are plenty of pediatric folk in the audience who have a lot more to say about ADHD in childhood, but I am an adult neuropsychologist and I will be speaking from an adult perspective. However, I will be going a little bit over the diagnosis as it is outlined in the DSM-5, a little bit about what we know about stimulant medication, and maybe take a look at what even is ADHD. Do we know what has the last decade taught us in the research before going on to the importance of history, a little commercial for what neuropsychology can do for you with some case examples from our local population, which leads right into some diversity considerations pretty specific to the population that we all see here in New Mexico. So to start with, psychologists always like to start everything with defining the terms. And attention, it's both simple and complex, and that's in action and in definition, actually. The basic definition of attention is the ability to recognize and respond to changes in the environment. But if you look at what we think of it neuropsychologically, it is not an ability. It is not a unitary construct. It is multifactorial. There are many, many parts to attention that involve other specific abilities like auditory and visual orientation, simultaneous processing of various stimuli, to be able to discriminate between competing stimuli, and all of these things actually recruit a bunch of different brain regions. So attention doesn't live anywhere localized. The right hemisphere seems to have a preference for it, but there's no one discrete region we can say, there is attention. And of course, when you move on to concentration, concentration requires attention. It's in the definition. Concentration is the ability to maintain attention on relevant stimuli and to ignore irrelevant stimuli. When we try to measure this in a neuropsychological way, typically we start simple and move to the more complex because it makes sense to do it that way. If we started complex and someone didn't do well, perhaps the difficulty is in the more basic function. So it helps to start with simple attention, measure their ability to repeat a string of numbers. That's, your basic attention, and then go from there, adding complexity and adding increasing demand. So we can go from simple attention to focused, which is usually coding and cancellation tasks, to focus on the relevant stimuli, and typically under time pressure. I know I'm making this sound really fun for everyone, right? And patients really enjoy it. No, they don't. Sustained attention and vigilance, which I think most are probably familiar with, continuous performance tests, very often used in the diagnosis and the evaluation for ADHD, where there's a 16-minute task and you sit at a computer and you hit a key only when you see a particular stimulus appear. That's my least favorite test to take. I took it as a graduate student and I came up quite impaired. However, it doesn't mean I have ADHD. I think I had grad school at the time. Divided and attention and working memory sort of overlap. We have some measures in the Wechsler Adult Intelligence Scale, the arithmetic subtest, and sequencing subtest that tend to be good measures of divided and attention and working memory. And then rapid shifting, which is not just shifting, but shifting under time pressure. And we have some Dellis-Kaplan executive functioning scales. The subtests that switch are really good for measuring that kind of thing. And I should mention that all of this, when we measure, and it seems like a lot of tests to measure attention, which should be one cognitive domain, but we do want to measure all of the parts, how those are working to form the whole, as well as everything else about a person, all of their cognitive functions, as many as we can measure, because we don't want to just look at attention in isolation, even the many parts of attention in isolation. We want to look at those performances in the context of a comprehensive neuropsychological assessment. And I will share a question that I got from an anonymous trainee from long ago, nobody here, someone far away in another state, who asked the question, shouldn't we just test the cognitive domains we expect to be impaired? So in the example of attention deficit hyperactivity disorder, ADHD, shouldn't we just test attention and see if that's impaired? Short answer, no, but long answer, because one item, one test score, one performance on any one measure means nothing in isolation. Our tests, neuropsychological tests, tend to be pretty sensitive, but not very specific individually. It's really the overall profile of scores that has a greater specificity to tell us what is happening. So a cognitive profile characterized by impaired attention, for example, might be any number of things if you only measure attention. But if the pattern includes difficulties with language and executive functioning, that could be a primary progressive aphasia. If it's characterized by impaired attention and processing speed and visuospatial difficulties, well, that could be a liver problem. Liver does impact your brain, believe it or not. So just the attention being impaired could be a lot of different things. And so that's why we like to make sure that we measure everything and look at that overall cognitive profile. Why is attention impaired? In a lot of things. Attention and concentration are pretty delicate in terms of cognitive functioning. There are a lot of factors that can impact attention and concentration out in the world and on testing. Things like auditory or visual impairment. I just presented a case in the last hour where it was a dementia evaluation and there were no hearing aids. So, these tests were screamed at the patient and he had a couple of low scores that could be accounted for by not being able to hear, not attending. Of course, linguistic and cultural differences. I would be remiss in any talk that I give if I did not mention these, and we will be talking about those a little bit later more specifically as they pertain to specific cases. Medication and substance effects, chronic pain. Chronic pain can be very distracting. There are many general medical conditions that can impact attention, from seasonal allergies to a urinary tract infection, having had a recent seizure. I mean, really think about how you felt the last time that you had the flu. And imagine someone like me in your face saying, repeat this list of words, or here are some numbers. I want you to repeat them back to me. You're probably not going to do very well, and you're probably going to be very mad at me. So general medical is always something to consider. And poor sleep, fatigue, particularly if a patient has not slept well the night before. I have had more than one patient fall asleep. And if you're giving a test of sustained attention and they haven't slept, that's a very good chance right there that they're going to fall asleep during that test a couple of times. And it might not be that obvious. They may have those little micro sleeps, but poor sleep can really do a number on your attention and concentration. Distractions in the testing environment. None of us, I think, probably work in the quietest of places, at least pre-COVID. We probably had a sort of bustling clinic that we were working in. And I used to actually work right in a room next door to a pediatric neuropsychologist. And when I was doing a dementia evaluation one day, there was a pediatric evaluation next door, and the parent was in there during the clinical interview. And as I was testing my patient, I hear the parent start yelling, "Put your pants back on, put your pants back on." And I thought, well, maybe I'll just ignore it. My poor patient said, "Did you hear that?" And I said, "Yes." And he said, "Good. I thought maybe I was hallucinating." So you can imagine that mid-task, he's not going to do very well on that test. And speaking of hallucinations, psychiatric symptoms from acute stress to internal stimuli of hallucinations can be very distracting. So this is a very delicate sort of set of cognitive functions. So what about significant attention problems, regardless of any of these factors, across time and space and environments? That is when we have the concern for ADHD. Again, I'm going to just one more time remind you of my disclaimer that I'm not a pediatric neuropsychologist, so I won't be discussing ADHD in children extensively, just sort of as it pertains to the developmental history of an adult. And I hope that the pediatric folk amongst us don't get bored. They can probably tell you a lot more about this than I can. They can definitely tell you much more about this than I can. But just to review, ADHD in the DSM-5 is listed under neurodevelopmental disorders. And of course, like everything in the DSM, has specific criteria that must be met. The first being a persistent pattern of inattention and hyperactivity, impulsivity that interferes with development or functioning. The symptoms must appear prior to the age of 12, which is a change from the previous version, which was the age of 7. So now we have a little bit more of some development to make this judgment call. Symptoms are present in 2 or more settings, and that includes a list of symptoms that everyone here, I'm pretty certain, has seen already. Pretty extensive list of what to look for, and a note that clear evidence has to be present that symptoms interfere with or reduce quality of social, educational, or occupational functioning. And then my favorite criterion for everything in the DSM, criterion E, which states that the symptoms do not occur exclusively during the course of schizophrenia or other psychotic disorder and are not better explained by another mental disorder, for example, mood disorder, anxiety disorder, etc. The reason that we have this is because of the significant overlap in symptoms of many mental disorders, particularly, again, in an adult population, and ADHD. So something can better account for attention symptoms, and I just went through all of the things that can possibly impact attention, and we treat that condition, whatever it is, and attention improves, then we have been parsimonious in our diagnosis and we are targeted in our treatment. And many patients come to me with a list of 9 psychiatric diagnoses, and probably they meet DSM-5 criteria for all of them. But do they actually have all of them at the moment that are impacting them? And do we need to address these conditions as separate entities, or can we treat one that may overlap with 3 others and then do a very sort of efficient job? One of my favorite things of all of the many things that I love about neuropsychology is the ability to make recommendations to treat the most likely condition that is impacting a person most significantly, and then test the patient again to see how their performance has changed. For me, that experience really feels like clinical science in action. So again, we have DSM-5 symptom lists. There are a lot of them. They're not meant to be used as a checklist in isolation to make a diagnosis, sitting and sort of saying, yes, all of these things are true before the age of 12, particularly in an adult who may be 40 or 50 years old. These symptom lists should be considered in the context of a few things. The developmental appropriateness. Is this developmentally appropriate to have this attention problem? If you see some hyperactivity, is the patient expected to have grown more to a certain point where they are less hyperactive, or are they 4? At 4, I think a lot of people are pretty hyperactive, but is it developmentally inappropriate is the question. Do these symptoms appear across settings? And then, of course, criterion E. And I would like to also add, even though it's not right in the criteria, it's somewhere in the DSM, I believe in the back, the cultural appropriateness of particular symptoms. One of the symptoms that is included in the ADHD diagnosis is essentially the same as intrusive thoughts, which could be PTSD. And both ADHD and PTSD have a lot of the same symptoms cognitively. And there are cultures particularly within New Mexico, particularly our indigenous cultures, who might report intrusive thoughts, but may minimize them because it is culturally not appropriate to directly discuss negative experiences. And I have seen this contribute to diagnoses of ADHD in this population when actually it's probably more consistent with PTSD. So some of those, the list of symptoms, some of the symptoms, actually all of the symptoms should probably be considered pretty heavily within a cultural context, particularly when we know certain things about our local population and their cultures and beliefs. It is also worth noting that in the DSM, there is no requirement for a specific cognitive profile or evidence of an attention deficit on testing. There's no mention of, attention scores must be a standard deviation and a half lower than expected for age. There is nothing like that in the DSM. We don't have that requirement to make that diagnosis. So ADHD is a behavioral diagnosis, and behavior is the target of treatment. My understanding for children that behavior is the target of stimulant medication, and stimulant medication has been shown to improve behavior. The improvement in behavior is what leads to academic performance being improved as well. And hopefully the point of this is hopefully this will keep the developmental trajectory on track and they won't miss those academic and developmental milestones because of the hyperactive and inattentive behavior. The question that keeps coming up throughout the literature and over many, many years is this just helping the behavioral symptoms, or is it actually directly impacting academic productivity and accuracy? And there's been a couple of really great review articles that have gone back and looked at some of these studies where maybe productivity was looked at, but not accuracy. And one of the more recent ones in 2019 showed that Ritalin, methylphenidate, that was used with primary school age children, along with a placebo and another in the control group, and had actual objective school measures that, examining these studies, there were 34 of them over 3 decades, including 1,777 children under these conditions, and found that symptoms, the behavioral symptoms, significantly improved on Ritalin. And academically, the only significant difference was math productivity and accuracy. And one of the interesting things about this particular review article is the difference between the effect sizes, where the behavioral symptoms had a large effect size when they were improved on Ritalin, and the academic changes were small to medium, demonstrating what we have sort of seen in literature up to this point, that stimulant medication for the treatment of ADHD in children tends to be very effective for those behavioral symptoms. But haven't we heard a lot about stimulant medication being a cognitive enhancer? And this is the question that's particularly important, I think, in an adult population, because of the questions that we are called to answer. I see a lot of graduate students who say, I've always had these problems, but they're so much worse now. I'm pretty sure I have ADHD. I looked it up on WebMD. Thank you, internet. And you think, okay, well, I can test you, but what is this? What is driving this? And sometimes it's the GRE or the LSAT or just graduate school in general, because of this belief that it is stimulant medication enhances your cognition. But does it really boost test performance or cognitive abilities? Will it actually get you a better score on the MCAT or help you pass the bar exam? These are the questions that are particularly pertinent, obviously, to an adult population. And we have some science. There is some evidence that stimulant medication is better in adults for motivation and confidence. There have been a couple of studies in college students without ADHD given stimulants and placebo, and it turns out that their performance is not significantly different between groups. But if there is a measure of confidence, how confident are you in your work? The people who had stimulant medication reported increased confidence in the work that they did. There was another study that tested people first without any sort of drug, and then tested them again with a placebo and a stimulant. And actually both groups had test scores that improved. And that was attributed to results on a survey that was, did you expect to do better after you got this drug? And they did. And that enhanced confidence and that performance expectancy. If you give me the stimulant, I bet I'll do better. Even as of this year, we're wondering about the efficacy as a cognitive enhancer. Still looking back at the vast amount of literature that has come up before this, and doing a lot of review articles that are coming out because of this history of mixed results and possibly some publication bias. So, there are these groups going back and looking at these studies. Another one recently in 2021, looking at 128 studies, again, found that placebo and stimulant effects did not differ on cognitive measures. And the other question that has always sort of persisted is, this works for children. We can give them stimulant medication and the behavioral symptoms go away and they can engage in education as they, get that out of the way. But what about the long-term effects? Does that mean that when they are 20, that their attention and executive functioning abilities will be better because they were treated with stimulant medication? And that there are also mixed results in the literature there too, but there is some evidence that behavioral interventions may have better long-term effects than medication, particularly on executive functioning. Medication seems to be much more effective in children for behavior, but when it comes to thinking and memory and other cognitive functions, it looks like behavioral interventions may be better in the long term. So maybe using them together gets you the immediate result and the long-term result when they're used in tandem. But what is it? What is ADHD? Can we define it? Can we pin it down, say, this is the etiology, it's this neurochemical imbalance or this structural difference? And if so, can't we then find a better way that's consistent to treat it? What is it? Well, we don't necessarily have a great solid answer for that. From a brain standpoint, there are a variety of brain differences that are seen at different ages. Some have seen some delayed maturation. A couple of studies have seen delayed maturation specifically of white matter. And this recent study in 2018 actually looked at unmedicated adolescents, children through adolescence, and saw that there were no differences between those with ADHD and those without ADHD in earlier childhood, but in adolescence, the white matter integrity of the adolescents looked like it hadn't matured as quickly as those without ADHD. And that's actually, it's an interesting study because of the unmedicated nature of the entire population that they studied. It's tough to study ADHD because there might be confounding effects from stimulant medication. So when you're talking about brain changes, we are medicating developing brains. And when we look at the differences, it could be due to medication. So it is kind of a difficult thing to study. Another earlier study regarding white matter differences seemed specific to the corpus callosum, but these were medicated children. So, is it the corpus callosum? Is it all of the white matter? Not sure. Does medication impact the white matter development? Possibly. There are also, there have been found to be some delayed volumetric differences that have been shown in some studies to become non-significant in adulthood, really suggesting that this is a delay, that this is developmental delay that you can see on neuroimaging. A lot of cortical thickness studies that have suggested that it's just a cortical thickness delay that eventually basically catches up in adulthood, although there are some studies that have shown it doesn't necessarily entirely catch up in adulthood. And again, does medication help that? We're not sure. Some have found delayed development in surface area, cortical surface area. And again, sometimes these studies indicate that there's a sort of catch up. Some of them indicate they do not catch up. And the least support so far looks like atypical gyrification, the folding of your brain, which has to do with both cortical thickness and surface area. So you would think maybe that would have more support, but actually it seems to have the least support for that theory. But it does look like there is a lot of brain research out there that suggests that this ADHD thing is a developmental delay. But also there are lots of studies that have found no significant brain differences between groups. So that leaves us a little better off than we started, I think, but with many unanswered questions. We can't necessarily say this is the etiology of ADHD, although there are some conditions in childhood, like perinatally, postnatally, very early in development that are associated with ADHD, but it doesn't 100% account for all cases of ADHD. So we can't say this specific thing is happening, and we can't say, you know, this specific treatment is right for everyone. So what do? We still have to diagnose this stuff. We still have to treat it. And particularly for those of us who work with adults, how are we supposed to do that for a developmental disorder that has to emerge before the age of 12? Well, the other question is, how often do we think that, are we expecting symptoms to persist? We have these longitudinal studies, again, with very mixed results. From 4% to 66% of children with ADHD have persisting symptoms into adulthood. That's a big range. What are we supposed to do with that? Base rates aren't really being helpful here because we don't know how much to expect to see symptoms of ADHD in adulthood. In addition to that, those of us who sort of almost meet in the middle, the pediatric people who see late adolescents, early adult patients, and adult neuropsychologists who see down to age 18, we're both sort of in that in this no man's land of an age range where we don't have fantastic normative data for this particular age range. We don't know necessarily who should claim this particular group of people because they are still developing. So in that sense, they're still in the developmental period, and shouldn't pediatric people be evaluating them? But every time I speak to my pediatric colleagues, they say, 19, the patient's so old. Patient's too old for me. And I get it, because to me, it seems really young. So there's this gap of resources to be able to evaluate this population, which unfortunately with ADHD, you can still see a pretty pronounced deficit on testing, and they usually are still in school. And you do often, particularly into the late 20s, see a mild cognitive profile that's what you might expect for someone with attention problems. The good thing is that if you're, late teens and in your 20s, there's more access to the information of your developmental period, your early childhood. People who are younger tend to be able to tell you about their elementary school experience, whereas someone who's 67 may not, and there may be fewer collateral resources available. There's pretty much always fewer collateral sources available for adults, because I'm not going to call your second grade teacher when you're 42 and ask how you did in school. That's not going to happen. And in fact, even school records often are not accessible when you have reached a certain age. So it's pretty difficult to evaluate and diagnose ADHD in retrospect for people over 30. You really do need a clear developmental history prior to the age of 12 that is consistent with the DSM criteria, and obtaining that information is very challenging the older your patient is, particularly if there are other factors that are related to, say, our rural population. Our education system varies widely in the state, and we do have tribal lands and reservation schools. We have public schools. We have a very dark history of Indian boarding schools, and trying to evaluate in retrospect, particularly in those situations, is very challenging. And we in the adult world are usually limited to self-report, what the patient tells you, and then on self-report measures. And unfortunately, a lot of our self-report measures in this area don't have embedded validity scales. So we are not entirely sure how much this actually represents what they're experiencing, or are they in distress and over-reporting, or perhaps drug seeking, unfortunately, for stimulant medication. So performance validity measures are a must more and more in the field of neuropsychology. They are a must regardless, but definitely in this particular, answering this particular question. There's a whole body of literature about motivation and performance validity when you're assessing adults for ADHD. I figured everyone probably has some experience in this area and doesn't need a whole list of references on a slide. So I figure you're familiar, and you probably just believe me that we really need to do performance validity measures for these folks. So again, we need a clear developmental history. We need current attention problems interfering with multiple areas of life. And we need the absence of other explanations or causes that better account for cognitive difficulties in our adult population. And recall and remind you that there's no specified cognitive profile for ADHD or any sort of quantification of difference. No, attention must be impaired by a measure of a standard deviation and a half below expectations. Still, we've got none of that. So if there's no guidelines about this, why am I telling you, hey, neuropsychology can help you? Especially because we know neither symptom report by the patient or neuropsychological test performance are specific to the diagnosis of ADHD. Instead, we have overlapping symptoms with many, many other disorders. And I'm going to show you a very busy slide, but don't try to read everything. I'm just going to tell you what it says. It is a big table from an article in 2010 that attempted to see what measures we had that could tell ADHD patients from controls from people with bipolar disorder, because bipolar disorder and ADHD have very many overlapping symptoms. And of this particularly comprehensive battery that looks pretty standard for adults, we don't really have very many measures that can tell the difference between these populations. BDI endorsement seems to fall right in the middle for ADHD patients between controls and people with bipolar disorder. Some recognition on memory tasks. People with ADHD tend to perform better than people with bipolar disorder, and tend to perform worse than controls on a sequencing task. But that's it. You see this list of measures that have been given, and these are the only things that were found in this particular study to tell these groups apart. And yet again, I'm still saying that neuropsychology can help you out. So what do we have that is sensitive to ADHD and specific to ADHD for adults? What are we going to use if not our standard type of test battery? What can we do? Here's another table from 2011 that shows, okay, what is sensitive to attention problems and ADHD in adults. And again, not very many things. I was pleased to see that IQ is not something that you can use to tell these two groups apart, controls and ADHD patients. Some reaction time, an ADHD score on the TOVA, and the Wender Utah rating scale, both the 25 item and the 61 item, as well as the Brown. I am a big fan of the Wender Utah. I really like this rating scale. I include it in all of my evaluations for ADHD in adulthood. It compares the endorsement of childhood symptoms to adult males or females with a history of ADHD, with a history of depression, and then a control group. And you can calculate Z-scores to see where your patient fits the best. The downside is this is another one of the self-report measures that we have that does not have an embedded validity scale, but you can look for over-reporting depending on that calculated Z-score. So sometimes you'll get very significant symptoms that have been endorsed, but they don't fit any of the three populations. And I do tend to see that pattern in the case of PTSD, because there is no PTSD group on the Wender Utah. So sometimes you do see psychological issues and distress that don't fit quite with any of these populations. But it is pretty sensitive, and I like it a lot for adults. What else can we do? We can't just give the Wender Utah rating scale to everyone and make decisions based on that. I think you heard me say earlier, we don't want to base our opinions on any one test or one number or one performance. And you know that I have just advocated for a comprehensive neuropsychological evaluation, and we don't have fantastically sensitive measures for ADHD to diagnose in adulthood. So what I like to tell my trainees is you are the most sensitive measure in the room. And I don't mean just rely on your clinical judgment. Don't run out and say, Lynette said that I can just make this judgment. That's not what I'm saying. I'm saying you have the skill and competence to use these imperfect tools that we have with a population that they were never meant to address, being a minoritized population, and determine what is going on with your patient. That is a very long-winded way to say that I stole this from Kathy Holland. When I was a graduate student, Kathy Holland came to speak in class, and all of us got a particular question. She asked all of the students a particular question, and my question was, what do you do if you only have an hour with a patient? And I, as a student, said, panic. And she said, history, history, history. I think I probably quote her every day. This week I can count, I've quoted her 3 times because I think that this is a particular pearl of wisdom, particularly when we are talking about trying to diagnose ADHD in an adult retrospectively. Asking questions about the onset. When did this start? Instead of saying, did you have symptoms before the age of 12? We can ask different questions like, how did you do in school? Did you take the SAT? Did you take the GRE? How did you do? Did you have to take them twice? Did you need extra preparation? All of these questions that can get at how someone was functioning in childhood and over time. Another great question to ask adults when they are in for an evaluation for ADHD is, why now? What has happened recently that has caused you to come in and get evaluated? Sometimes it's, oh, my son was diagnosed and I feel like I had all these problems in childhood. Okay. Sometimes it's, I saw something on YouTube and then looked up stuff on the internet, which is my less favorite thing to hear. But sometimes there is some, sort of driving factor that can be very informative when evaluating for this particular thing. Asking about the course. We don't necessarily know, even over the extensive research that we have, if it gets better over time. Some say yes, some say no, even as early or as recently as 2021. We don't know if it is supposed to get better over time, but we do know that it does not get worse. So something getting worse in an adult is probably something else. And hopefully, if we assess in a comprehensive way, we can figure out what that is. The other factors that can impact functioning that should be considered are, language, culture, and educational differences, medical conditions, all kinds of things, TBI, infection, just lots of medical conditions can impact attention concentration, and psychiatric conditions that should also be evaluated to see, is it the bipolar disorder that is impacting you the most, or is this mostly ADHD symptomatology? And what neuropsychology can do is look at those other factors. Because we can't test specifically for ADHD, we can take a comprehensive history, and then we can tell you what it's not. By incorporating all of the knowledge of all of these things from a neuropsychological perspective, do we think that it's ADHD or an autoimmune disorder? Neuropsych testing can tell those things apart. They will have, ADHD might not have a specific cognitive profile, but autoimmune disorders tend to have a particular cognitive profile. So we can rule things out, or we can discover what is the most likely contributing factor. I'm going to show you a couple of cases. I'm not going to put up all the data because that would take too long, and I don't think everyone's super excited about data like I am. So we'll just go with the most known Wechsler Adult Intelligence Scale and the WERS, which I just explained to you a minute ago. Here is a 24-year-old biracial monolingual English-speaking right-handed male with 18 years of education. Just a couple of little snapshots of data here. He is performing extremely well. His performances on the Wechsler Adult Intelligence Scale are high average to very superior. But the interesting thing is that working memory and processing speed, while they're in the high average range, represent particular weaknesses. All of his other numbers were great. He is functioning pretty well, even within the context of expecting him to be superior. But his Wender Utah rating scale, his endorsement is consistent with males with a history of ADHD. And in fact, he had a prior diagnosis of ADHD. He was treated with stimulant medication in grade school. He had a fantastic primary care physician who said, I'm going to send you for a sleep study before I send you to get evaluated for ADHD, ruled out any sort of sleep disorder. Said that symptoms were worse in childhood, got a bit better in high school, but now he's in graduate school and struggling with the increased demands. And I had no other evidence of anything. He had no mood issues. He was psychiatrically stable, just really the easiest sort of patient to evaluate that there ever was, with these mild weaknesses. And yes, I said, okay, I think it is. I think these are residual weaknesses from ADHD diagnosed in childhood. And I think that you could use some academic accommodations based on that, and sent him on his way. Not always the case. Similar patient, but a bit older. I have a 42-year-old white monolingual English-speaking right-handed female with 18 years of ed. So kind of similar education level, similar functioning, cognitive functioning, very high functioning individual. But again, and you can see like that pattern on the Wechsler Adult Intelligence Scale, working memory and processing speed are again lower than expected. So wouldn't this just be, she was diagnosed with ADHD at 38. She also was diagnosed at that same time with PTSD secondary to childhood physical abuse. And then she had COVID about 9 months before this evaluation, developed POTS, postural orthostatic tachycardia syndrome, and chronic pain, fatigue, daytime sleepiness. Partner says now she's got some breathing difficulties related with sleep. Despite this very similar pattern, if I look at her other data, she's reporting a lot of mood symptoms, and that particular pattern of verbal fluency, which I won't expand on too much because I don't have time, but that pattern to me says that there's a sleep disorder. I don't want to confirm a diagnosis of ADHD when I don't see the historical support for it. And this cognitive profile suggests much more that there is sleep apnea and significant PTSD symptoms. So in this case, I could not confirm that diagnosis of ADHD. And finally, a 40-year-old left-handed male diagnosed with ADHD at 36. I'm not going to give you a lot of his data, but he did have impaired verbal encoding. He was not learning new verbal information. And he did have variable executive functioning and processing speed, similar to the other two cases that I just showed you. And I've got some DCAFS scores here that show just how variable his performance was. But you can see that it's really verbal performances that are significantly lower than everything else. And he had difficulty with verbal information, learning that. He was left-handed, so it was difficult to necessarily localize things. But this guy, he had poor school performance. He broke his right arm in the 5th grade, but he started out right-handed. He attributed the switch to that broken arm. And he reported losing time. He was unable to focus and couldn't hold a job in adulthood. And he was diagnosed with ADHD due to that. He was given stimulant medication and he felt much worse. Everything seemed to get worse for him. So he came to me and I got this data. And from that, his history and the data, I figured he probably had some left temporal lobe issue. And his report of losing time and these staring spells in childhood, I thought maybe it's epilepsy. And it was left temporal lobe epilepsy confirmed by EEG. So why, in this case, was my test battery different? And where is that Wechsler Adult Intelligence scale? Why wasn't I giving that? And those reasons that I had for structuring things the way I did, are they the same reasons for the delayed diagnosis of epilepsy? Yes, I have withheld something very important from you in this case. If I gave you the full demographics, we have a bilingual English and Tiwa Pueblo male with 8 years of ed, with a fractured atypical education obtained in entirely rural areas in New Mexico. So does that mean that we could have ruled out ADHD right away? Possibly not, but there are factors that led to both the diagnosis of ADHD instead of epilepsy and why I structured my battery the way that I did. There are lots of diversity issues that we should consider anywhere that we are, but particular to our local population, bilingualism is big, and not everyone will say that they're bilingual. You can ask patients, is English your primary language? They will say yes. And then if you probe a little bit more, oh, I learned Spanish first and I learned English after the age of 5. That has some pretty significant impact on neurodevelopment. So we want to know those things, and it can impact test performance. If you're bilingual, there's the cognitive load theory. You're thinking in 2 languages at once, which can be an attention issue and can slow you down. There's the theory of linguistic relativity. It's complicated, but there's a whole movie on it with Amy Adams that was really great about how your language that you learn first influences your perception, your cognition. It's a theory, but it's a good one. We have a lot of different quality of education in the state, varying widely from our urban areas to more remote rural areas, and of course the history of boarding schools. Along with that, the rural life or life on the reservation, it does vary from location to location, but there are high rates of poverty and issues with lifespan healthcare, from prenatal to postnatal to TBIs sustained in adulthood. All of these things are sometimes not even documented or reported if they have conditions like TBI. And there is a lot of trauma and the related substance abuse that goes with it often. And then just cultural factors, like if someone is a little performing slower on a reaction time task, perhaps they are from a culture that prioritizes accuracy over speed, or the different salience of the stimuli that you're using. Different cultures have different methods of problem solving. Mood symptoms can be a significant impactor, and they might not be reported, or mood symptoms might look different in certain cultures. and of course, stereotype threat, particularly if there is a doctor from the majority culture evaluating someone of a minoritized culture, the stereotype threat and what that patient thinks you're thinking about them. And all of these things should be taken in consideration when we are evaluating for anything, but particularly for these adult evaluations for ADHD. So I believe there's no way that we can be competent without also being culturally competent. And I want to, when in my own work, acknowledge our very unique and diverse population in the state that we live, and make sure that that's reflected in the questions that I ask and the measures that I use, the interpretation of the data, the diagnoses that I give, the recommendations that I make, and of course, the talks that I give. So I'd like to leave you with the wise words of Kathy Holland again. History, history, history. It's really important for everything that we do as mental health professionals and physical health professionals, but particularly when we're trying to assess attention problems in adulthood, and particularly for our diverse population in our location, where these difficulties in attention and these cultural factors overlap. And I know I went a few minutes over, supposed to finish at like 10 till, but I talk a lot, what can I say? I will stop sharing, and I'm happy to answer questions.
Thank you. I have a question. Dr. Abrams, I'm Juan Bustillo. Thank you very much for a wonderful presentation.
Oh.
And you know, for us clinicians, psychiatrists or psychologists who see adults, we have obviously noticed in the last 10 or 15 years, more and more adults that are self-referred or referred by another provider to screen ADHD or to make a diagnosis of ADHD in adults. And the patient often is already interested in getting stimulants. And I've seen over my practice here in New Mexico over several years, how learners have become more and more confident and comfortable with using screeners, self-report screeners. And there's a variety of these. And I think they're probably way less sophisticated than the Wender Utah that you like. But I've noticed several of these learners feeling comfortable saying, well, you know, we did the screen and the person scores really above the recommended level. And I want to start this person on stimulants. And bear in mind that invariably, the clinical decision-making issue is not between someone that just endorses symptoms of ADHD as an adult, and you're sort of thinking of them versus a healthy person. These are all people that have a psychiatric history of mood disorders and have taken things that they feel haven't worked, or substance use very often, or even psychotic disorders. So I suspect I know what you're going to answer, but I mean, what kind of confidence should us clinicians have who deal with adults have with these screeners?
I've seen these patients who get diagnosed based on a screening measure, get diagnosed stimulants right then and there, and have complex medical and psychiatric conditions. I see them in my clinic 6-9 months later saying, you know, I have PTSD and my nightmares are out of control and I can't sleep and my anxiety is really high. And as a psychologist who doesn't prescribe, because I don't, I have to accept that a diagnosis of ADHD is kind of a de facto prescription for stimulant medication. And in these complex cases, it has been my tactic to address the things like PTSD or like some sort of physical condition like diabetes, get them under control and see how the patient is doing then. And that's my philosophy of neuropsychology. I don't just want to evaluate someone and send them off. I want to go have them do specific things, take care of specific disorders, and then come back and see how much better or worse they're doing. Because the stimulant thing can be tough for some people. It can make them a lot worse. I've had patients with PTSD develop psychotic symptoms after getting stimulant medication. So it's a tough call, and I'm very glad I don't prescribe. I never want to. I know I probably could pursue that, but I'm not gonna because of these issues where there are complex factors, and instead of hitting all of them at the same time, maybe it's a good idea to start with other things first.
So is it fair to tell the learners that I supervise, even if this person scores really high on the self-report, if they have clear history of depression, and if they going back to history, if you are relatively confident that they did well in school, maybe they weren't stars, but they were not in special ed, and then that this is probably not ADHD, regardless of what the screening says.
I think that's very close to what I think is appropriate, what I say myself, which is it's possible that this patient met criteria for ADHD prior to the age of 12, but today, what is impacting them the most? So, it's probably something else that is more, that can contribute more to what they're experiencing. And that is the thing, that if you treat it, maybe if they did have ADHD, maybe it's not going to be impacting them so much at 47. It's complicated, I know. But I also would say it's fantastic if you teach your trainees just in any sort of focus that anyone has here. Just if you don't know, refer to neuropsychology. I feel like neuropsychology has a lot to offer. I mean, obviously I'm biased, but I'm happy to see your patients.
And on that note, thank you so much. We really, really appreciate the thoroughness of your presentation, and we look forward to further collaborations.
Thank you so much for having me. I loved being here.
Thank you. Bye.